Hello, my name is Christy Martinez, and I'll be presenting Human Immunodeficiency Virus, or HIV, along with Case Study 75, Acquired Immunodeficiency Syndrome, from Breuer's 100 Case Studies in Pathophysiology. In Case Study 75, Acquired Immunodeficiency Syndrome, the patient, MC, has a chief complaint of, "I've been out of breath, I've had a cough, and I feel run down. I think that I may also have a fever. This came on fast, and it has been going on now for almost a full week." MC is a 29-year-old Caucasian male who was diagnosed with HIV 2.5 years ago. He has regular follow-up visits at the HIV clinic every 2 to 3 months, and has most recently been seen 6 weeks ago. He has been stable for about 11 months on his current antiretroviral regimen, after developing drug resistance to his regimen prior. He currently presents with dyspnea, persistent and nonproductive cough, and fatigue. Human immunodeficiency virus is a viral infection that can be transmitted from an infected individual through sexual contact, blood, breast milk, and from a mother to her newborn through the placenta or from blood contact during delivery. HIV weakens the immune system and makes the carrier more susceptible to many illnesses, including other viruses and certain cancers. HIV does not have a cure, but it can be prevented and treated with antiretrovirals, often giving the carrier a full lifespan. However, if left untreated, HIV can progress to acquired immunodeficiency syndrome, or AIDS. AIDS is the most advanced stage of this disease and has caused millions of deaths throughout the world. According to the World Health Organization, there was an estimated 39 million people worldwide with HIV by the end of 2022. And in that same year, 630,000 people died from causes related to HIV. According to Rogers, in the United States, there are over 1 million people living with HIV, with 36,801 new cases in 2019. Rogers also states that while most racial and ethnic groups are seeing a decline in infection rates, there are a few groups that have unfortunately seen an increase in rates, including American Indian and Alaskan Native populations. HIV is an envelope virus, meaning it contains a lipid bilayer membrane that protects the virus and allows it to enter and exit cells without harm. The virus attaches to the T helper cell receptors via its glycoproteins. Once attached, it releases the contained viral RNA along with integrase, protease, and reverse transcriptase into the cell. The reverse transcriptase then converts the viral RNA into viral DNA. The DNA, using the integrase, moves into the nucleus where it binds with the cell's DNA. Then the virus uses RNA polymerase to make viral mRNA. When cytokines have activated the host cell, the mRNA travels out of the nucleus and into the cytoplasm, where it makes the proteins for the virus. The mRNA and enzymes then combine and push through, creating its lipid bilayer from the host cell wall. It is then released from the cell and repeats this process on other T helper cells. Upon first infection, this process happens rapidly and often causes flu-like symptoms. This stage of the infection is called acute HIV and begins 2 to 4 weeks after the initial infection. The immune system responds to this infection by activating T cytotoxic cells, which kill the infected T helper cells. This response, while essential to slowing the virus, kills billions of T helper cells in the process. T helper cells are produced by the bone marrow and can be replaced at a rapid rate, making it possible for an infected person's T helper cell number to remain stable for years. While the immune system can replace the T helper cells, the body is in clinical latency. Clinical latency can last for 10 to 11 years in the untreated individual. If the infected person is treated with antiretroviral therapy, latency can last for decades. Some individuals never achieve latency, and the virus can progress rapidly, while others can remain in latency even without treatment. When the bone marrow can no longer keep up with the T helper cell replacement, T helper cell numbers begin to decline. Once the T helper cell number reaches 200 cells per microliters or below, or certain cancers or infections occur, the individual is considered to have the most advanced stage of HIV, AIDS, or acquired immunodeficiency syndrome. In case study 75, suspicion for AIDS is gathered first from MC's past medical history. MC developed tuberculosis 11 years prior. 3 years ago, MC had a perianal ulceration that was caused by the herpes simplex virus. Around the time of his HIV diagnosis, he experienced oral candidiasis or thrush. He had a recurrent thrush infection 20 months ago. More recently, 10 and 14 months ago, he experienced anemia that required treatment. MC also had cytomegalovirus retinitis in his right eye and received 13 weeks of IV treatment until his second catheter line infection, when treatment was halted. 6 weeks ago, the patient was treated for pneumocystis pneumonia. During his treatment, he developed an allergic reaction to the medication and was placed on an alternate medication, with which he was able to finish treatment. He's currently on several antiretrovirals related to his HIV diagnosis. MC's social history includes engaging in unprotected anal and oral intercourse with multiple male partners for approximately 7 years, with one partner being deceased from AIDS-related complications. He also has a history of tobacco, alcohol, cocaine, and IV drug use. He's currently unemployed and lives with his mother. Upon exam, MC appears ill, thin, and anxious. His blood pressure is slightly elevated at 130/87. Heart rate is 90. He's tachypnic with respirations of 30, and he has a fever of 101.9. Further exam finds his left eye with signs of CMV retinitis, lymphadenopathy in the neck, axilla, and groin, and crackles in the lungs. Testing reveals pneumocystis infection. This explains the crackles in the lungs. Unfortunately, this patient's labs reveal what many may have already suspected. MC's C4 cells are at 119 cells. As stated in a previous slide, a C4 count below 200 cells is considered stage 3 of HIV or AIDS. In addition, MC is experiencing some opportunistic infections, which are also indicative of AIDS. Romans 3:10 says, "There is none righteous, no, not one. We're all sinners in the eyes of God and should never let our own opinions of someone have us treat them in any other way than in love." It is important to remember this as a Christian provider, as we will see and care for many people that have lifestyles that we may not necessarily agree with. We must look past that and care for all our patients with the love and respect we are given by God. Patients should be cared for not just for their disease process, but emotionally and spiritually as well. Providing compassionate care allows the light of God to shine through us and onto our patients. A few questions related to the case study that might interest you. HIV/AIDS is a very complicated disease process. The immune system is not the only system negatively impacted by the infection. What other organs or systems are being affected by MC's HIV? Second, what is the difference between HIV and AIDS? And when do you think MC began displaying symptoms of AIDS? As mentioned on the previous slide, holistic care will be important for this patient. What non-medical treatments would be beneficial for MC? This concludes my presentation on HIV and AIDS. Thank you for listening, and I hope you found it informative, and I look forward to further discussion with you all.